Closing remarks. So, like what we saw, I mean, these statements that we have is all newly diagnosed patient MHSPC should be offered triplet therapy as a standard of care. So you should look at it as should be offered, not should receive. So if you go to, for example, go to Apple stores, as a salesperson, you should offer the best products in your stores, not to offer some products based on the patient's, based on the customer's financial capability. So after you offer, based on the customer financial capabilities or the requirements of your customer, that you tailored according to it. But everybody who entered to your office should be offered the best product. So we think that triple therapy is the best products we have at the moment. And talking about cost, anything new will be costly. So as times go down, like for example, robotic surgery is getting more and more cheaper nowadays. Talking about these cost toxicities and the drug toxicity is like how we argue about doublet therapies in 2015. People have been talking doublet therapy is more toxic than ADT monotherapy. But today, doublet therapy has become the standard of care. So down the road, triple therapy might become the standard of care. And the Enzamet trial, we talk about Enzamet trial. Enzamet trial was not designed to answer this question, first of all. There are mixtures of meta-Crohn's patients, heme-Crohn's patients, and there's a mix of patients inside. And docetaxel's groups are not randomized, and the study is not powered to answer these questions. So we think that this is a novel treatment. All newly diagnosed patients should be offered, but whether or not they should receive the treatment is a second issue, and it's the discretion of the physicians to assess the patient whether they can or they should receive the treatment. And as for the drug and toxicities and the financial toxicity, as what we answered just now. Thank you.
Thanks, Vincent, for your input. But generally, to offer without the intention to give is just semantics. So, going back to Dr. Raj's point, whether or not docetaxel is really just an innocent bystander, we have also the stopgap meta-analysis, which evaluated the effect of docetaxel in addition to ADT for MHSPC. It was found to be most suitable for patients with poor prognosis based on high disease volume and bulkiness of the primary tumor. But there wasn't any benefit for patients with metachronous or low volume disease, as Alex has previously pointed out. So I think just to summarize, we are not fighting the fact that triple therapy has a significant OS benefit, but it just raised the question, is it necessary for treatment intensification for low volume disease and for metachronous disease, and can we justify the associated morbidity? So the crux of management lies really in patient selection. So for fit and younger patients, there's the most survival benefit, but at the cost of increased toxicity. But we do agree that SOC for low volume or metachronous MHSPC will still be doublet therapy as per guidelines. There is a need, obviously, to tailor to individuals with their comorbidities, their preference, the availability, and money is always the biggest problem in healthcare. And we have big studies on healthcare economics, and it's a very, very prevalent problem, especially locally, what we can offer our patients. So also looking at cancer characteristics, disease volume, times of MET detection. And we know that the landscape of prostate cancer is constantly changing, even in the oligometastatic setting. I think the next debate will address that with the advent of metastasis-directed therapy even. So can we really say that triple therapy should be offered upfront for everybody? Our answer is no.
For the excellent debate. Now I would like to open the floor to ask any questions, any burning questions. Maybe we can get some of the judges to comment also. Maybe Wei Chong, since you are the one who is sitting here giving the docetaxel, you may want to comment on it.
Great points from both sides. I think the fact that it's all doesn't really favor the proposition a little bit, because in cancer is never all, but it's about how you argue it, right? I think the issue of volume is the crux of the matter. I think we just have to understand that. First point is the trial results are a little bit heterogeneous in this space, especially with regards to docetaxel, which is why the debate topic is the way it is. There is a lot of space for argument. All right. The role of ARSI, I think, is a little bit more established. I think most would agree that generally, even for low volume disease, we tend to offer ARSI as a standard of care in addition to ADT. I think one thing that you might want to consider in debating such a point is how do we assess high volume disease, and is this adequate, right? Because you know that times are changing. You have heard about PSMA PET. You have heard about the advent of PSMA PET. All the trials conventionally, they use conventional staging methods, right? CT bone scan. Is that really enough? For example, in the Pt.10 trial, even low volume patients, about a third of low volume patients actually receive docetaxel as a standard of care. It's just because standards of care at that time were a little bit variable, right? So even in the Pt.10 trial, and in ARASENS, obviously both high and low volume received triplet therapy, right? That's just the way the trial was structured. So there are a lot of issues with all these trial designs per se. And I guess one of the things that I would bring up, and a point for contention, because this is a debate, so you bring up points for contention, right, is whether or not our staging modalities are actually adequate to assess volume, and maybe it's not so adequate, and therefore maybe there's a role to offer triplet even in patients who are typically assessed to be low volume disease, or perhaps you may argue that because the trials are conducted as such with conventional staging modalities, therefore we should base our volume assessment on no standard staging modalities and maybe not bring PSMA PET into the picture, right? So these are points for contention, no answers, but fertile ground for debate, right? Yeah.
Actually, I just wanted to try to score a point for my side, because you mentioned earlier in your talk, and I think the exact words were consolidation of treatment earlier on has been shown to be...
Just want to remind you that the debate is over.
Thanks, Claire. Thanks, Claire, for your input. Thanks, Claire. But I have the mic now. Yeah. So I think you mentioned that consolidation of treatment early on in the disease has shown to be the way to go. So I just want to get your thoughts. Do you think we are right to support triple therapy as a SOC? Because we are just waiting for the data to come out in the future and with the right kind of trials to be performed.
So intensification of systemic therapy is the way to go in prostate cancer. That's the direction the field is evolving in, without a doubt. The question here is how you intensify therapy. Right, how intensify therapy? When you balance the toxicities of the treatment, so for example, ARSI, very well tolerated, right? Generally doesn't cause anything. ARASENS and Pt.10 are prime examples of that. Okay, you have ADT and docetaxel, you add ARSI, hardly any additional toxicities. All right, so that's why it's standard of care. All right. Chemo is a different thing, okay, but chemo is time limited. Okay, we all know that. 6 cycles of docetaxel, end of story, right? Patient goes into surveillance with ADT and ARSI. But of course, in that 6 cycles, they may get problems, okay? And if you look at the historical trials, right, coming from a historical perspective, right, there's CHARTED, and there's the GETAP trial for docetaxel. 1 positive, 1 negative trial. And when you have 1 positive and 1 negative trial, you always have to ask yourself why. Right? The GETAP trial is negative for docetaxel intensification in metastatic HSPC. Okay, but the CHARTED was positive. And in CHARTED, when they did a subgroup analysis, okay, the main benefit was driven by high volume. The main benefit was driven by high volume. The criticism at that time was that GETAP actually included a different population of patients, maybe more low volume patients, more patients with good prognosis. Okay, when we give treatment, it's always like that. Systemic therapy is always like that. Your magnitude of benefit is always dependent on your initial prognosis. Okay, the worse your prognosis is, usually the more the magnitude of benefit, just because for a treatment that ostensibly will give the same percentage relative risk reduction, all right, for a higher risk patient, that absolute risk reduction by magnitude will be higher. That's just the truth of the matter. So it's about selecting the patients. Now, I would argue, and many oncologists would also argue, that our current risk stratification models are lacking. Okay, we use volume, but even volume is a very gross stratification. You look at chartered criteria, right? It's 4 bone lesions, one of which is outside the axial skeleton, or visceral mets. How many prostate cancer patients have visceral mets? You tell me. Mostly we see just all bone disease, right? All bone disease. How do you accurately assess bone disease? Is bone scan enough? Is PSME PET enough? Okay, are there patients that, for example, a PSA level may not be totally reflective of the burden of disease, maybe because they are low PSA secretors, right? Are there patients that, you can have microscopic disease elsewhere, but it's just not being picked up on radiology? Do we have better stratification tools? Do we have better biomarkers to stratify our patients? All right. So if we are talking about intensifying systemic therapy, biomarkers is not something, unfortunately, that we can ignore. Current practice, we can make do with what we have, okay, but there's always room for development, and unfortunately, I think right now our risk stratification models are somewhat inadequate, but that's just a product of the times. That's just something that we have to work with. So yeah, so for me, you get my point, right? Yeah.
So triple therapy will be the way to go. Thanks, Dr. Tan. Thanks.
Debate. So as the moderator, I think my take-home concluding statement is that always have your medical oncologist as your best friend, and make sure they are readily available. But unfortunately, just to let you know, Wei Chong didn't pick up my call when I called him 2 days ago. Okay, let's move